Welcome back. In today's video, we will dive into bradyarrhythmia. Bradyarrhythmia usually arises due to some defect in the SA node or the AV node. It can be due to a defect in impulse generation, or a defect in impulse transmission to the atrial myocytes. The SA node primarily consists of two types of cells. The P cells, which produces or generates the impulses, and the T cells, which transmits the generated impulse to the atrial myocytes. In SA nodal defects, ECG abnormalities can be variable and intermittent. Multiple ECG abnormalities can be seen in sinus node dysfunction, including sinus bradycardia, sinus arrhythmia, sino-atrial exit blocks, sinus arrest, bradycardia, tachycardia syndrome. Let's learn how to interpret each of these in ECGs. Sinus bradycardia will be similar to normal sinus rhythm, but the rate will be less than 60 beats per minute. So in the ECG, there will be isomorphic P waves. All P waves followed by a narrow QRS complex. The PR interval will be normal and constant, and the P wave axis will be normal. The only difference being the RR interval will be more than 5 large boxes. Sinus arrhythmia is a normal physiological phenomenon most commonly seen in young, healthy people. The heart rate varies due to reflex changes in vagal tone during the different stages of the respiratory cycle. That is, the heart rate increases with inspiration by decreasing the vagal tone. And with the onset of expiration, vagal tone is restored, leading to a subsequent decrease in heart rate. Here the ECG will show normal sinus rhythm, and there will be no evidence of premature atrial contractions. The PR interval will be constant, that means there are no evidence of type 1 Mobitz AV block. Only the P to P interval lengthens and shortens in a cyclical fashion, usually corresponding to the phases of the respiratory cycle. Sinus pause. It results due to defect of P cells of the SA node to generate impulse. There will be prolonged absence of P wave for more than 3 seconds. That is around 15 large box. It can be due to intrinsic causes of the SA node, like degenerative fibrosis, ischemia, cardiomyopathies, and infiltrative diseases like sarcoidosis, hemochromatosis. Some other extrinsic causes include drugs like digoxin, beta blockers, and calcium channel blockers, autonomic dysfunction, hyperthyroidism, and electrolyte abnormalities like hyperkalemia. Treatment of sinus pause will include removal of extrinsic causes and pacing the heart. In tachy-brady syndromes, there will be runs of tachycardia followed by a long sinus pause. Now let's look at SA nodal exit blocks. Similar to AV nodal blocks, these are also of 3 types: first degree, second degree, and third degree SA nodal blocks. In first degree sino-atrial block, there is a delay between impulse generation and impulse transmission to the atria. Since we can only interpret atrial depolarization in an ECG, first degree SA nodal blocks are not visible in ECG, and requires electrophysiological studies for its diagnosis. Similarly, in third degree SA nodal block, none of the impulse generated are transmitted to the atrium, so these are also not visible in ECGs. The second degree SA nodal blocks are subdivided into type 1 and type 2 blocks. In second degree type 1 heart block, there will be progressive lengthening of the interval between impulse generation and transmission, culminating in failure of transmission. That is, the impulse generated in the P cells will get more and more delayed to reach the atria. This progressive delay will end in a missed beat. This phenomenon is called Wenckebach phenomenon. In an ECG, this will be characterized by progressive shortening of the P to P interval, followed by a missed beat. Whereas in second degree SA nodal type 2 blocks, the impulse transmission is delayed at a constant level, but some impulses are not conducted, resulting in missed beats. Here the P to P interval will be constant and there will be missed beats. Coming to the AV nodal blocks. It is also classified into first, second, and third degree AV blocks. In first degree AV block, there is delayed conduction through the AV node, resulting in a prolonged PR interval. This prolongation will be constant throughout the ECG. The second-degree AV blocks are again differentiated into Mobitz type 1 and Mobitz type 2. In Mobitz 1, there is progressive prolongation of the PR interval culminating in a non-conducted P wave. That is, the PR interval will increase with successive cardiac cycles and ultimately one impulse will not be transmitted. Whereas in Mobitz 2 there is intermittent non-conducted P waves without progressive prolongation of the PR interval. While Mobitz 1 is usually due to a functional suppression of AV conduction due to drugs or reversible ischemia. Mobitz 2 is more likely to be due to structural damage to the conducting system due to infarction, fibrosis, or necrosis. Mobitz type 2 is usually due to failure of conduction at the level of the His-Perkins system. In around 75% of cases, the conduction block is located distal to the bundle of His, producing broad QRS complexes. In the remaining 25% of cases, the conduction block is located within the His bundle itself, producing narrow QRS complexes. In complete heart block, there is complete absence of AV conduction, with none of the supraventricular impulses conducted to the ventricles. The perfusing rhythm is maintained by junctional or ventricular escape rhythm. In ECG, there will be AV dissociation, atria, and ventricles will be pumping at different rates. We can identify it by looking for variable PR interval. Under normal conditions, subsidiary pacemakers are suppressed by the more rapid impulses from above like sinus rhythm. Junctional and ventricular escape rhythms arise when the rate of supraventricular impulses arriving at the AV node or ventricle is less than the intrinsic rate of the ectopic pacemaker. Junctional rhythm is generated by tissue at the atrioventricular junction. In its ECG, there will be rate of 40 to 60 bpm. QRS complexes are typically narrow, less than 120 milliseconds. No relationship between the QRS complexes and any preceding atrial activity. While in ventricular escape rhythm, there will be a ventricular rhythm with a rate of 20 to 40 bpm. QRS complexes are broad, greater than or equal to 120 milliseconds, and may have a LBBB or RBBB morphology. This is also known as idioventricular escape rhythm. Lastly, let's discuss some more about other conduction blocks. The normal conduction system starts from the SA node, goes to the AV node and through the bundle of His, it goes into right and left bundle branches. The right bundle branch forms the Purkinje fibers of the right ventricle, whereas the left bundle branch divides again into anterior and posterior fascicle. So any conduction defect at each of these areas gives us certain ECG patterns. For example, a block at right bundle branch is usually called as RBBB. Similarly, there are LBBB, left anterior fascicle block and left posterior fascicle block. At times, there will be combination of these blocks, like an RBBB with a left anterior or posterior fascicle block. These are called as bifascicular block. Whereas when all three fascicles are blocked, we call it as a trifascicular block. Let's look at each one in more detail. In normal cardiac conduction, impulses travel equally down the left and right bundles, with the septum activated from left to right and the formation of small Q waves in lateral leads. In RBBB, the left ventricle is activated normally, thus the early part of the QRS complex correlating to septal depolarization is unchanged. There is delayed activation of the right ventricle as depolarization originates from the left ventricle across the septum. This produces a secondary R wave called as R' in the precordial leads. A wide, slurred S wave will also be seen in the lateral leads. Normal activation of the left ventricle means that cardiac axis remains normal in isolated RBBB. This abnormal depolarization will be followed by an abnormal repolarization, which appears as ST depression or T-wave inversion in leads V1 to V3. This is termed as appropriate discordance. So in ECG of RBBB, there will be QRS duration will be more than 120 milliseconds. There will be RSR- pattern in V1 to V3 giving a characteristic M-shaped QRS complex. Along with this, the S wave in lateral leads will be wide and slurred. Similarly in LBBB, the impulses travel first via the right bundle branch to the RV, and then to the LV via the septum. Septal activation is thus reversed, eliminating lateral Q waves. The overall depolarization vector from the right to left ventricle produces tall R waves in lateral leads and deep S waves in the right precordial leads. Delayed overall conduction time to the LV extends the QRS duration to more than 120 milliseconds. Appropriate discordance will show ST elevation in anterior leads and ST depressions with T wave inversions in the lateral leads. These changes does not signify myocardial ischemia. So how do we diagnose myocardial infarction in the setting of bundle branch blocks? For that we can use the Smith modified Sgarbossa criteria. We can suspect a myocardial infarction if there are concordant ST elevation by more than 1 mm in one or more leads. That is, the R wave is followed by an ST elevation of more than 1 mm in any one lead. Similarly, concordant ST depression of more than 1 mm in one or more leads of V1 to V3 is also significant. If there is discordant ST elevation with amplitude more than 25% of the depth of the preceding S wave, this is termed as proportionally excessive discordance. Lastly, let's briefly go through the remaining conduction blocks. In LAF or left anterior fascicular block, there will be left axis deviation, QR complexes in leads I and AVL, RS complexes in leads 2, 3, and AVF. Prolonged R wave peak time in AVL of more than 45 milliseconds, as the impulses reach the left-sided leads later than normal. While in LPF, left posterior fascicular block, there will be right axis deviation, RS complexes in leads I, AVL, QR complexes in leads 2, 3, AVF. Prolonged R wave peak time in AVF. In bifascicular block, RBBB with LAFB, there will be left axis deviation with RBBB pattern. So, there are M pattern in anterior leads, showing RBBB pattern, with a positive wave in lead 1 and a negative wave in AVF, showing left axis deviation. While in RBBB with LPF, there will be RBBB pattern with right axis deviation. In true trifascicular block, there is conduction delay in all three fascicles, RBBB, LAF, and LPF, causing a pattern similar to bifascicular block with complete heart block. Here there are typical M pattern in lead 1 with left or right axis deviation, showing bifascicular block. In addition to that, there is AV dissociation shown by P waves and QRS complexes beating independently to each other. That is all for today. Hope you enjoyed this video on bradyarrhythmias and heart blocks. If so, clicking the subscribe button will be deeply appreciated. Check our cardiology playlist to know more about ECGs.